Hey everyone, welcome back to Nurse Crit. My name is Chasen. I'm an acute care nurse practitioner. What is something that virtually everyone and their mama gets when they show up to the hospital? Yep, not hard to guess. A basic metabolic panel, or BMP. I know you might think this is a boring and trivial topic, but considering every patient gets one, it must be pretty important, right? By the end of this video, I hope all nurses will have a greater appreciation for the value of this blood test. The objectives for this video are to identify the individual components of the BMP, recall the standard reference ranges for each test, understand the physiologic importance of each value, and recognize clinical findings for derangements of each test. Entire books have been written on fluid and electrolytes. Since this is only a short video, I will not be going into the physiologic regulation or treatment of metabolic derangements, just their basic functions. In fact, an entire video could probably be dedicated to each test individually. If that's something you might be interested in, let me know in the comments. So, what is a basic metabolic panel? The BMP is a panel or collection of 8 individual values tested from the blood. It includes electrolytes like sodium, potassium, chloride, and calcium. It also tests bicarbonate and glucose levels, as well as kidney function. If you've been a nurse long enough, you might recall the BMP used to be called a Chem 7 or SMA 7, which is the same panel of tests as the current BMP minus the calcium level. If you still have an older doc ordering a Chem 7, just know that they want to check a BMP. Prior to electronic medical records, physicians would write lab results in their progress notes, and nurses also frequently jot down their patients' most recent lab values on their report sheet. To save time, there exists a standardized way to list out all the values. It is configured into a universal fishbone graphic. The conventional sequence is sodium, potassium, chloride, CO2, BUN, creatinine, and glucose. Because the BMP includes calcium, I personally add an extra line in the front and write it here. If we additionally test magnesium and phosphorus, I write those here as well. Please understand that the placement of the calcium, magnesium, and phosphorus are my own way of writing them down, as not universally recognized. I write it down this way to keep them near the other electrolytes and not somewhere else on a page. The normal reference ranges for each test in the BMP will vary from lab to lab, but in general, there are accepted values that nearly everyone considers to be normal. For sodium, the normal reference range is 135 to 145 MEQs per liter. For potassium, the normal range is 3.5 to 5 MEQs per liter. For chloride, the normal range is 98 to 106 MEQs per liter. The CO2, sometimes referred to as the bicarb, is 22 to 26 MEQs per liter. The BUN normal range is about 10 to 20 milligrams per deciliter, and the normal range for creatinine is 0.6 to 1.2 milligrams per deciliter. Both the BUN and creatinine actually vary slightly between sexes, but for ease of memorization, these numbers are sufficient. The normal fasting glucose is 70 to 110, but this is highly dependent on when the patient last ate or drank. And the last value in the BMP is the total calcium level, for which the normal range is 8.5 to 10.5 milligrams per deciliter. Now that you know the normal values, the next step is to understand the significance of each value and its function in the body. Sodium is the most abundant extracellular cation whose major function is maintaining serum osmolality. Osmolality is the concentration of dissolved particles in the blood which determines its tonicity. Sodium levels are largely affected by the hydration status of a patient. Too much or too little water in the body affects the sodium level. When you think about sodium, think about the brain as the most affected organ. Of course, the whole body is affected, but the brain tends to be the most sensitive to shifts in sodium. Hyponatremia, or sodium levels below 135, can produce neurologic symptoms like headache, irritability, disorientation, muscle twitching, tremors, weakness, decreased consciousness, psychosis, ataxia, seizures, and even coma. Hypernatremia, or sodium levels above 145, may present as restlessness, nausea, vomiting, thirst, fever, flushing, weakness, lethargy, confusion, twitching, tremors, seizure, or coma. As you can see, there are a lot of overlap in symptoms, and most are brain-related. The next electrolyte in the BMP is potassium. Potassium is the major intracellular cation that is responsible for aiding in nerve impulse transmission in the heart and muscles. Like sodium, changes in potassium affect the entire body, but when you think about potassium, think first about the heart. Drastic changes in serum potassium levels are going to primarily manifest in the heart, making a potassium imbalance potentially life-threatening. Hypokalemia, or serum potassium levels less than 3.5, can manifest as ECG changes, dysrhythmias, bradycardia, and even cardiac arrest. Non-cardiac manifestations include skeletal muscle weakness, paresthesias, cramps, decreased deep tendon reflexes, paralysis, as well as anorexia, nausea, vomiting, constipation, and ileus. Hyperkalemia, or potassium greater than 5, can cause ECG changes, dysrhythmias, heart block, cardiac arrest, paresthesias, weakness, paralysis, nausea, abdominal cramping, and diarrhea. Again, despite being opposite problems, both high and low potassium yields many overlapping symptoms. Chloride, the forgotten electrolyte, is the major anion in the extracellular fluid. I think it's extremely common for nurses and even doctors to completely disregard this value on the BMP. Its function isn't as blatantly obvious as all the other electrolytes. But I am going to say that chloride's greatest function is in regulating acid-base balance. In the Fishbone Diagram, chloride is right above bicarb, and you should understand that this column is the acid-base column. These two values affect serum pH. Without going into any detail about the Stewart approach or strong ion difference, just believe me when I say that chloride and bicarb are inversely proportional to each other. If the chloride levels are low, also known as hypochloremia, this will lead to a rise in bicarb, since they are opposite, and create a metabolic alkalosis. Conversely, high chloride levels or hyperchloremia will push down bicarb levels, resulting in a metabolic acidosis. You may have heard that giving normal saline can cause an acidosis, and this is because NS is a huge chloride load. A normal chloride level is at most 108, but NS has 154 MEQs per liter. Now can you see why normal saline is not so normal to the body? The next value in the BMP is the CO2. Newer nurses often mistake this for the PCO2, which is the partial pressure of carbon dioxide. But the CO2 on a metabolic panel is the measured serum bicarb. I will admit that the chemistry and explanation of why bicarb is labeled as CO2 is still over my head to this day, but the reason isn't really that important. Just remember that this CO2 equals the serum bicarb, which is the same as the bicarb level on an ABG, and its range is 22 to 26. Without measuring the serum pH, we can't know if the blood is acidemic or alkalemic, but we can definitely say the patient has a metabolic acidosis or alkalosis if the bicarb is too low or too high, respectively. Metabolic acidosis may present as tachypnea, decrease in cardiac output and BP, dysrhythmias, weakness, headache, confusion, stupor, nausea, and vomiting. Metabolic alkalosis may present as hypoventilation, twitching, weakness, tetany, paresthesias, confusion, seizures, stupor, nausea, and vomiting. The symptoms of acid-base derangements are often related to the secondary potassium and calcium disturbances that they create. The next column in the BMP contains the markers of renal function. The BUN and creatinine are still the standard tests for assessing the kidneys. Both of these are metabolic waste products that are cleared by the kidneys, so an accumulation of them usually indicates the kidneys are not functioning at a normal level. In general, the BUN and creatinine should rise together in a 10-to-1 to 20-to-1 fashion. If the BUN is much higher out of proportion to the creatinine, it is usually felt the abnormal value is from dehydration rather than actual kidney disease. Although routinely and universally utilized, the BUN and creatinine are only minimally useful tests. Nephrologists or kidney doctors use various urine studies to better evaluate renal function and dysfunction. In the tail of the fishbone is the glucose level. Like the BUN and creatinine, The glucose level isn't exactly super helpful, but is a decent screening test. It's really only useful if it catches severe hypoglycemia, which is low blood glucose levels. Low glucose levels are really bad for the brain. High glucose levels are difficult to interpret without multiple checks and under fasting conditions. The hemoglobin A1C is generally considered more useful in evaluating a patient for diabetes. In patients where the glucose level is greater than 3 or 400, there may be accompanying electrolyte disturbances like hyponatremia and hyperkalemia, as well as changes in serum osmolality. In clinical practice, we typically like to follow fingerstick glucose levels rather than the glucose on a BMP to guide our treatment. The last electrolyte to discuss on the BMP is the total calcium. This is a measure of all the calcium in the blood. Understand that of the total calcium, approximately 50% of it is ionized, meaning it is free and not bound to other anions. Only the free ionized calcium is capable of performing functions within the body. So in essence, the total calcium level is almost worthless. To truly know if a patient is high or low on usable calcium, an ionized calcium level needs to be drawn. But this is not a routine test included in the BMP, and it even requires a different collection tube altogether. Calcium has many functions in the body, like maintaining bone and teeth structure, but similar to potassium, it plays a major role in nerve impulse transmission. It can definitely affect the heart, but its clinical manifestations tend to be more obvious in the skeletal and smooth muscles. A low serum calcium or hypocalcemia can cause anxiety, confusion, irritability, paresthesias, especially around the mouth, cramps, and tetany. Other signs and symptoms include diarrhea, hypotension, and dysrhythmias. Elevated calcium levels, known as hypercalcemia, may manifest as fatigue, altered mental status, weakness, ataxia, hypertension, bradycardia, nausea, vomiting, thirst, constipation, and kidney stones. And that's the gist of the basic metabolic panel. Basic, but everyday useful. Even if you think it's a little boring, I think nurses should be a master of these 8 basic tests. Please help me out by sharing this video with your nursing friends and consider subscribing to my channel so you don't miss out on all the wonderful future learning. Thanks for watching, and I hope you will join me in my next video.